Hello dear viewers, in this video which is part 12 of continuous renal replacement therapy, I will be discussing part 6 of regional citrate anticoagulation where I will discuss precautions during regional citrate anticoagulation as well as limitations associated with this therapy. Conventionally, liver disease and shock hypoperfused state used to be considered as a contraindication to this therapy, which is no longer true. We will discuss these issues in more details. It is generally believed that patients with liver dysfunction have an impaired ability to metabolize citrate. Therefore, liver dysfunction has traditionally been considered a contraindication in using RCA. However, several recent studies have shown that RCA can still be used safely in patients with liver dysfunction or even liver failure without a significant increased risk of complications. There are two possible explanations for this. First, the liver is not the only place in the body that can metabolize citrate, but kidney, muscles and other tissue that contain the needed enzyme also can metabolize citrate. Second, traditional liver function evaluation indexes like ALT, AST, bilirubin, cholinesterase, child Pugh score, and model of end-stage liver disease score have a poor ability to predict citrate accumulation. Therefore, liver failure should not be regarded as a contraindication for RCA. Rather, these patients should be regarded as a special group and the changes of ionized calcium and other electrolytes should be closely monitored during treatment to identify those with citrate accumulation. It is possible to use a lower citrate flow rate combined with a lower blood flow while closely monitoring the ratio of serum total calcium to serum ionized calcium. Citrate calcium complex that enters the body is metabolized in the mitochondria through the tricarboxylic acid cycle, which is oxygen dependent. In patients with severe hypoxia, shock or mitochondrial dysfunction, citrate tends to accumulate because of the impaired tricarboxylic acid cycling induced by decreased mitochondrial oxidative chain activity. In theory, the use of RCA in these patients could be dangerous. However, clinical practice has shown that RCA use is well tolerated in patients with shock, especially in those whose circulation is improving. Therefore, there is still a lack of the criteria for evaluating the severity of metabolic impairment and RCA contraindication in these patients. Lactic acid is an important marker of severe tissue hypoperfusion, severe hypoxia, or mitochondrial dysfunction. Because lactate and citrate share the same metabolic pathway in mitochondria, citrate accumulation is often combined with hyperlactatemia. They are not causally related in pathophysiology but important marker of severe metabolic impairment and disease severity. Such patients usually have a very high mortality rate. Lactate might be used to evaluate citrate metabolic capacity. However, in a significant proportion of the patient with elevated lactate not associated with hypoxia or hypoperfusion, the tricarboxylic acid cycle in these patients may be expected to be normal without affecting citrate metabolism. Therefore, hyperlactatemia cannot be used as a diagnostic criteria for citrate accumulation nor a contraindication for RCA. For the ease of understanding, if citrate accumulation is there due to shock state, lactate will always be elevated, but opposite is not true, means lactate can be elevated without citrate accumulation if lactate is elevated due to reasons other than hypoxia, shock or hypoperfused state. Even if there is severe lactate accumulation due to hypoperfusion or hypoxia, RCA can be safely administered if lactic acid declines in the first few hours of treatment. Therefore, patients with persistent hyperlactatemia due to shock or hypoxia may have a higher risk of citrate accumulation than other patients, and such patients should be considered as a special group needing closer monitoring by measuring the total calcium ionized calcium ratio and pH. If total calcium ionized calcium ratio exceeds 2.5, an intervention to reduce the citrate load or to discontinue the infusion should be considered. The modes commonly used for CRRT include slow continuous ultrafiltration or SCUF, CVVH, CVVHD and CVVHD-F. SCUF mode does not require replacement or dialysate fluid and the amount of effluent generated is much lower than in other modes. If RCA is used in the SCUF mode, citrate calcium complex cannot be effectively removed by the semi-permeable membrane and the excessive complex entering the systemic circulation makes the patient prone to metabolic alkalosis. Therefore, RCA is not used in the SCUF mode. In CBVH mode, RCA can be safely used regardless of pre-dilution or post-dilution. The main disadvantage of CVVH is that it is limited by the transmembrane pressure and filtration fraction when it is necessary to increase the flow rate of replacement fluid to quickly remove the complex such as in metabolic alkalosis or citrate accumulation. CVVHD mode eliminates solutes by diffusion without limitation of transmembrane pressure and filtration fraction and can increase dialysate flow rate to increase the proportion of complex clearance through the semi-permeable membrane to alleviate metabolic alkalosis or reduced citrate accumulation. RCA can also be safely used in CVVHD. The main limitation of CVVHD is that the citrate replacement fluid means balanced solution alone cannot be used. Because the citrate replacement fluid should be infused pre-filter in the extracorporeal circulation to exert anticoagulant effect and also as pre-dilution replacement fluid which should not be used as dialysate. CVVHDF has the advantage of both CVVH and CVVHD and it can achieve higher clearance efficiency by increasing replacement fluid or dialysate flow rate which is conducive to the management of metabolic complications of regional citrate anticoagulation. So to summarize, there is no absolute contraindication of regional citrate anticoagulation. The traditional contraindication like liver disease and shock state are no longer a contraindication. These should be considered a special group with high risk which requires close monitoring for citrate accumulation by monitoring pH, total and ionized calcium. RCA cannot be used in slow continuous ultrafiltration mode of CRRT as metabolites cannot be cleared effectively in effluent. Balanced citrate solution cannot be used in CVVHD mode because CVVHD does not require replacement fluid and citrate replacement fluid cannot be used as dialysate. CVVHDF provides the most effective clearance if citrate has to be cleared during complications like metabolic alkalosis or citrate accumulation. Here I finish. Hope this video is useful to understand the nuances of regional citrate anticoagulation. If you have any questions, please write them down in comment section. See you in my next video on CRRT part 13 and regional citrate anticoagulation part 7 where I will discuss regional citrate anticoagulation and energy. Till then, bye and take care.